All right, good afternoon, everyone, and welcome to the webinar, Opioid Addiction, Increasing Access to Prevention, Treatment, and Recovery, sponsored by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center. My name is Samantha Holcomb. I'm a Director of Practice Improvement for the National Council for Behavioral Health, and I will be serving as your moderator this afternoon. Before I begin, I'd like to draw your attention to some important webinar logistics. During today's presentation, your slides will be automatically synchronized with the audio, so you will not need to flip any slides to follow along. You will listen to audio through your computer speakers, so please ensure they're on and the volume is up. You may send us questions at any time during the webinar by typing your question into the Ask a Question box on the lower left portion of your player. Depending on the question, we may type an answer back to you or save it for the end. We'll answer as many of your questions as time allows. The webinar is being recorded, and an audio version of the entire webinar, as well as a PDF of the presentation slides, will be available on the Webinar Archives page of the National Council website within 48 hours of the broadcast, as well as sent out to participants. Following the webinar, we invite you to please complete a short survey. Finally, if you need technical assistance, please click on the question mark button in the upper right corner of your player to see a list of frequently asked questions and contact info for tech support if needed. And now, if you're ready, Cicely, I'll pass it over to you.
I sure am. Thanks so much, Sam, and thanks to the National Council for partnering on this important webinar with us. Good afternoon, everyone. It's an honor to be joining you today. My name is Cicely McWayne, and I serve as the Military and Veteran Affairs Liaison at SAMHSA's Office of Regional Policy and Practice Innovation. I'm honored to be joining you today with two amazing speakers that are going to give us some wonderful overview and information on this important topic. And I'll be giving you a little bit of information about just who they are a little bit more in depth shortly, but wanted to talk a little bit about the work of the Service Members, Veterans, and Their Families Technical Assistance Center so you know about this important work and why we're bringing you webinars like these today. If we can go to the next slide. Just to share the disclaimer that the views, opinions, and content that you'll hear in the presentations today don't reflect necessarily the opinions or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services, but are the views of those presenting the materials themselves. And the next slide again. So since about 2008, SAMHSA has partnered with our states and territories to strengthen our behavioral health systems that serve our service members, veterans, and their families across our country. Our goal has really been to provide expert technical assistance through our TA Center, and we're leading this effort to make sure that substance use and mental health issues among all Americans, including our service members and veterans and their families, are well understood and that access is being increased daily. Next slide. We do this through a number of objectives, which include strengthening our ongoing collaborations among our military and veteran civilian stakeholders, helping to provide a centralized mechanism for our cities, states, and territories to learn, connect, and share from one another, and increasing awareness of access to resources and programs that strengthen the behavioral health care systems for our SMVF. We support coordinated responses to this work and help to encourage our cities, states, and territories to implement promising and best practice as well as evidence-based practices whenever possible. This work is critical, and we know that it can't be done alone, and so connecting everyone together makes a real difference when we're able to learn from one another and what's worked and to learn about how to implement those best practices. Our next slide talks a little bit about some of the ways that we actually can do this work, and we do that through Policy Academy work, Implementation Academies, webinars like the one you're on today, thank you for joining, and our learning collaboratives and on-site virtual and expertise consultations, as well as the resource dissemination of things like the webinars, but also other materials. So we hope that folks will be able to learn a little bit about the work that the TA Center does and join us through our listservs, making sure that you know that other important topics like the one you're hearing today focused on SMVF and opioids comes from hearing from folks like yourselves across the country on the pressing issues that you need to learn more about. So again, as we go into this webinar, keep that in mind and let us know about some of the issues and the pressing concerns that you may have in the roles that you're playing in serving our military and veteran families. Next slide. Today's objectives really are going to be focusing on a few things. The first is describing how the Veterans Administration addresses the national epidemic of opioid use disorders through its prevention, treatment, and recovery supports. and helping to recognize how community systems of care are imperative to helping our service member, veterans, and their families in long-term recovery. I'm going to describe how we can build and illustrate mental health comorbidities with increased risk of opioid use and the response that we provide for them. Next slide. We're going to talk about mitigation and overdose prevention strategies, as well as the long-term opioid therapies that are out there working today, and helping to learn a little bit about the recovery-based integrated model of care for this population. We hope that this webinar will help demonstrate the importance of a paradigm shift in pain management, especially among our service members and veterans, and helping folks understand the multimodal and integrated team-based pain care biopsychosocial and interdisciplinary care models that are being innovatively used across the VA systems, but also integrated in our community setting. Next slide. It's important to note that we are addressing this best practice methods in order to really prevent opioid use, help to treat those that are experiencing addiction currently, and supporting our service members and veterans who are currently in recovery. Community services should help form a person-centered network to provide measurably improved health, wellness, and quality of life for all individuals, including our service members, veterans, and their families. This is a critical effort for all of us, and we know that opioid use and addiction is something that's touching families across the country. In particular, we have some unique needs that are facing our military and veteran families, and we're so excited to be joined by two expert speakers today in this field. Let me tell you a little bit about who you're going to be hearing from. As I mentioned, they're wonderful clinicians doing wonderful work across the nation, and also happen to be two veterans themselves. First is Dr. Karen Drexler, who serves as the National Mental Health Program Director for Substance Use Disorders in the Office of Mental Health and Suicide Prevention at the Veterans Health Administration. Dr. Drexler is the National Mental Health Program Director, and prior to this current role, she served as the Deputy National Mental Health Program Director of Addictive Disorders within the Mental Health Service Line and Patient Care Services at VA Central Office. She has also served as faculty at Emory University School of Medicine, where she was the Director of the Substance Abuse Treatment Program at the Atlanta VA Medical Center. Additionally, she has served as Residency Training Director for Emory Addiction Psychiatry Residency Training Program, and continues to serve as a teacher and mentor to Emory students, residents, and faculty. Dr. Drexler has also worked as an attending psychiatrist at the Wright-Patterson U.S. Air Force Medical Center on the faculty of the Wright State School of Medicine. Her research interests include the neurobiology of addiction, clinical trials, and health services research for addictive disorders. She attended medical school at Duke University School of Medicine and completed her psychiatric residency at Wilford Hall U.S. Air Force Medical Center in San Antonio, Texas. She is joined today by Captain Michael Flaherty, retired U.S. Navy Reserve clinical psychologist, and also founder of the Institute for Research, Education, and Training in the Addictions. Dr. Flaherty founded the Institute IRETA in 1999 and served as the principal investigator of its SAMHSA CSAT-funded Northeast ATTC from 2001 to 2011. He has decades of experience in prevention, intervention, and treatment research and policy development related to substance use, addiction, and recovery. Prior to founding the Institute, he was the vice president of the St. Francis Health System in Pittsburgh, Pennsylvania, and director of the Institute for Psychiatry and Addiction Services. He's authored and overseen 20 federal and foundational grants, a number of articles and books on a variety of topics related to the need for a unified vision and scientifically and experimentally aligned practices, and wellness recovery in the U.S. Dr. Flaherty has been an invited guest to White House Office of National Drug Control Policy and serves on numerous key advisory groups. These include the Annapolis Coalition, Workforce on Development, ONDCP Synergy Group for Screening and Brief Interventions in the Addictions, and the Recovery to Practice Initiative. He's currently leading projects, preparing clinical monographs, and researching the importance of understanding further common themes of personal recovery. His work comes from driven by his personal experience in the U.S. Naval Reserve, as I mentioned, with 27 years of service on active and reserve duty. He's also the father of an active duty service member currently. So you can hear from these introductions that we have two experts that are going to be walking us through this really informative information. It's a lot to take in, As we shared these resources, and the slides will be available to you as well. So without further ado, I'm so excited to hand things over to Dr. Karen Drexler, who will get us started talking about the amazing work that's being done there at VA. Karen, thank you for joining us today.
Thank you so much, Cicely. And can you hear me?
I can hear you great.
We can hear you loud and clear.
Okay, super. So thank you everyone for your kind attention today, and thank you, Cicely, for that very kind introduction. I'm going to go through a lot of information quickly. Please feel free to ask questions. I'm going to talk today about our VHA strategies to address the national epidemic of opioid overuse, diversion, and opioid use disorders. The tiny graph that you see on the lower right shows that of the veterans in the U.S. today, slightly less than half use at least one VA benefit, and about 6 million use VA health care. And that's really the focus of my talk today. Next slide, please. So briefly, I'll quickly give an overview. I'll talk a little bit about how we got here with the opioid crisis, and then some about the VA opioid safety initiatives. There have been multiple initiatives to address various aspects of this complex crisis. And then a little bit at the end about what you can do to help veterans in your sphere of practice or sphere of influence. Next slide, please. So chronic pain is a major public health problem. About 30% of U.S. adults suffer from chronic pain. The costs are greater than cancer and heart disease combined, and as you can see by the graph on the right, pain reports have actually been increasing since the late 1990s when we started paying more attention to pain. Next slide, please. And the slide on the left is a now iconic slide published by the Centers for Disease Control and Prevention, showing that as kilograms of opioid analgesic medications sold per 10,000 Americans increased over time, so did the deaths due to opioid overdose per 100,000 Americans. So thankfully that's on a different scale. But then the third line, the purple line, is admissions for opioid use disorder treatment also increased with a similar slope, and that's on a scale of per 10,000 Americans. So these, as opioid sales grew, so did deaths due to overdose, and so did admissions for opioid use disorders. The maps on the right show that these trends also held true by region. The middle part of the country was less likely to prescribe opioids at a higher rate and less likely to experience opioid overdose deaths. As you can see, the lower map shows opioid pain reliever sales, and they're very high on both coasts and in the Appalachian region, and the upper map shows overdose death rate per 100,000, and it's high in those same areas. Next slide. This slide gives an update, whereas the previous slide left off at about 2010, 2011, when it was published. This shows what's happened since then. And there's been several trends that I want to highlight. First of all, the green line at the top is overdose deaths due to prescription opioid pain medicines. And as you can see, there was a steady increase right up until 2011 when the CDC sounded the alarm bells. And then prescribers started changing their prescribing practices, and it looked like that was going to provide some relief. We had a dip in the overdose deaths due to prescription opioid pain medicines briefly up until about 2013 when it started rising again. And by 2017, the deaths due to prescription opioid pain medicines are at an all-time high. But as you can see, there are other trend lines as well. And even before we started changing our prescribing practices around opioid analgesics, the deaths due to heroin, illicit heroin, started increasing around 2008 and 9 and really took off around 2011. And then another trend that just seemed to come out from nowhere, starting about 2013 and 14, was a rapid increase in overdose deaths due to synthetic opioids other than methadone. Those are specifically fentanyl, carfentanil, and similar analogs. So that even with changes in our opioid pain medicine prescribing, there have been changes in the illicit market that have also increased the riskiness of using opioids, such that overdose deaths have continued to increase. Next slide. And this is a graph, again, from the CDC that essentially illustrates information from SAMHSA's National Survey of Drug Use and Health, showing that for every one prescription or illicit opioid overuse death in 2015, there were 18 people who had a substance use disorder involving heroin and 62 people who had a substance use disorder involving prescription opioids. Of the almost 3,000 people who used prescription opioids, a minority became addicted to them and a tiny minority died, but the number of people using prescription opioids has increased so much that that has driven a decrease in the life expectancy for Americans for the past 2 years. Next slide. So after looking at the population data, I'd like to bring it home by sharing a story of a veteran that I treated about 8 or 9 years ago now, really before the CDC published that landmark study. At the time, she was a 54-year-old licensed practical nurse, and she was referred to me for substance use disorder treatment after having experienced an overdose. I was an attending physician at our intensive outpatient treatment program, and I learned the story that she had injured her back at age 24 while she was on active duty and was treated briefly with opioid pain medicine, as was the style at the time. Bed rest, heat, ice, and then exacerbations, because she continued to work in the healthcare field, continued to move patients periodically, and would re-injure her back. Those exacerbations were treated progressively as the sort of fashion for treating musculoskeletal pain changed, so that eventually she was treated with opioids long-term together with muscle relaxants. And she developed a high tolerance, she developed a drug hunger that drove her to seek out multiple providers and then to buy pills. She wasn't buying heroin, but pills on the illicit market, and she overdosed. Next slide, please. So keeping that case in mind, I think she illustrates very nicely the DSM-5 criteria for prescription opioid use disorder. There are 11 criteria for most substance use disorders. If a patient's taking prescription opioids as prescribed, then we do not count tolerance and withdrawal. So we make the diagnosis based on the other 9 criteria. And she met really 8 of the 9 criteria. She had strong desire and craving for opioids. She was constantly thinking about her next dose. She continued to use in hazardous situations like driving when she was too impaired to drive. She used more than she intended. The one criteria she didn't meet was she didn't have any desire to cut down or control her opioid use. It was really her primary care provider that had said, I'm not going to prescribe opioids again unless you come to SUD treatment. So that's why she arrived on my doorstep. But she was spending all of her time driving to different doctor's offices. She was no longer working. She was ostensibly retired, but at an early age, and that was really related ostensibly to her medical condition, but driven largely by her opioid use disorder, which was tied up with her pain complaints. Next slide, please. So the prevalence of pain in veterans is greater than in the U.S. population as a whole. 66% of veterans versus 56% of non-veterans report pain in the prior 3 months. And pain is more severe among veterans than among non-veterans, as you can see with the graphs below. And this is true at every age except for the oldest age cohort, and true for both male and female veterans. Next slide. And pain is more complex in VA. Veterans who report pain also commonly report other complex conditions like post-traumatic stress disorder, or PTSD, and mild traumatic brain injury, or TBI, Both of these conditions are risk factors for developing substance use disorders. And so veterans with pain and these co-occurring conditions who are exposed to opioids are at increased risk for developing an opioid use disorder. Next slide, please. The risk factors that have been best studied for overdose and development of opioid use disorder are related to the opioids themselves. You can have all of the other risk factors of PTSD and TBI and other co-occurring conditions, but if you are not exposed to opioids, you cannot become addicted to them. And opioid prescribing characteristics, both the dose and the duration, are highly predictive of both overdose and opioid use disorder. But medical and mental health comorbidities also play a role. Next slide. So this shows from our own VA data, this is by Oliva and colleagues that was published in Psychiatric Services in 2017, that as the co-occurring disorders, that for certain co-occurring disorders, the risk of being on opioid pain medicine, having adverse events related to that, can double or increase up to 23 times. So medical comorbidities like HIV and liver disease can double the risk. Mental health comorbidities like depression and PTSD can increase the risk from 2.5 to almost 6-fold. And then substance use disorders, particularly stimulants, opioid use disorders, and sedative hypnotic disorders can increase the risk 8 to 11-fold. And then certain healthcare utilization events like an inpatient admission for mental health treatment, a detoxification admission, or an admission for overdose or suicide attempt increase the risk 16 to 23-fold. Next slide, please. This slide illustrates both of the points that at higher dose ranges, there is a high risk, but the co-occurring disorders also confer risk. And because of the knowledge that we've had now for at least 8 years that prescribing opioids long-term for chronic non-cancer pain is risky, many providers and patients have worked together to ensure that they're prescribing lower doses of opioids for pain. And yet, the majority of overdose and suicide deaths in VA among veterans on opioids occurred at the lower doses. Again, that's because we've been working to bring doses down, not to prescribe those higher doses. So the vast majority of veterans receiving opioid pain medicines are receiving doses less than 50 milligrams of morphine equivalents daily. So those at the higher dose ranges have higher risk, but the majority of the events occurred at the lower dose ranges. And at all dose ranges, the majority of the events occurred in veterans who had co-occurring substance use disorders, that's the green part of the bar, or mental health disorders only, that's the red part of the bar. Next slide, please. So what can we do to help protect veterans against the adverse events associated with opioid pain medication, prescribing, and opioid use disorder? So we have a multi-pronged approach. I've organized them into 3 categories. We've developed clinical practice guidelines to guide the treatment for pain management as well as opioid use disorder treatment. We've developed some opioid risk mitigation strategies for patients who remain on long-term opioid therapy. And we're working to increase access to safe, effective pain management, opioid tapering, as well as opioid use disorder or OUD treatment. Next slide, please. First, and most importantly, there's been a paradigm shift in pain care. In the 1980s, there was a lot of enthusiasm about multimodal pain care that was sort of usurped by enthusiasm about opioids in the 90s and early 2000s. We now know that there's no completely safe opioid dose threshold below which there are no risks. and that even short-term use can result in addiction. And that any initial gains, we know that opioids are very effective for acute or short-term pain, like associated with surgery or an acute injury, but we know that that relief is short-lived because of opioids' tendency to build up tolerance. And so prolonged use of opioids, especially at the higher doses, may lead to sensitization and increased pain or hyperalgesia. And patients on opioids may actually experience a functional decline in the long term compared to patients with similar conditions who aren't exposed to opioids. So when evaluating a patient with new pain, we strongly recommend against initiating opioids for long-term pain management. Next slide. Our guidelines, so that's illustrated by our number one recommendation. We strongly recommend alternatives to opioid therapy, such as self-management strategies, non-pharmacologic treatments, and when medications are used, we recommend non-opioids like non-steroidal anti-inflammatory drugs over opioids. Next slide. There are certain high-risk categories, like younger patients less than 30 years of age, those who are taking co-occurring benzodiazepines, for example, that we would recommend against it. But for those who have been on long-term opioid therapy who are not suffering adverse events, we recommend against any abrupt discontinuation and rather risk mitigation strategies like informed consent, informing the patient of the risks and the limits of the benefits, urine drug testing or UDT, prescription drug monitoring program checks or PDMP, overdose education, and naloxone prescribing, including educating a loved one so that they can administer naloxone in the event of an overdose. We also recommend assessing for suicide risk and reevaluating the benefits and risks at least every 3 months for long-term opioid therapy for pain. Next slide, please. So again, we've talked about the risks associated as doses go up, so we recommend lower doses. We recommend avoiding long-acting medications, but the dosage reduction should be individualized to the patient and avoid sudden reductions. Taper slowly. And if the person has developed opioid use disorder, like the patient I mentioned, offer medication-assisted treatment. We also made some recommendations about acute pain because oftentimes treatment for acute pain turns into treatment for chronic pain. And so if opioids are prescribed for acute pain, we recommend 3 to 5 days at most. Next slide, please. In the VA, there's a lot of recommendations around treatment contracts. We have a different approach, which is informed consent. So the idea is that any treatment should be a shared decision-making approach where the clinician offers expert opinion about risks and benefits, and then the patient is able to choose from a menu of recommended treatments. And so we have improved and updated our patient education materials as well as our informed consent. Next slide, please. And this timeline, which I apologize for the small font, it's too small to read. It's just basically giving you a visual of all the different initiatives we've had to improve care for opioid use disorder and pain in VA, starting back in 2007 all the way up to the present time. Next slide, please. One has been our opioid safety initiative, which started back nationwide in 2013. There's a summary of it that was published in the Journal of the American Medical Association, Internal Medicine, JAMA Internal Medicine, back in 2017. The OSI aims to reduce over-reliance on opioids and to improve the safe and effective use of opioids when indicated. And it's had a comprehensive strategy that includes better pain management, risk mitigation strategies, like I mentioned, and improving access to addiction treatment. Next slide, please. Another initiative has been our Overdose Education and Naloxone Distribution Program, or OEND. An important part is educating veterans at risk about overdose and their loved ones of how to recognize the signs and symptoms, then prescribing naloxone. We prescribe now the FDA auto-injector as well as the nasal spray. The nasal spray has been the most popular formulation. And we target both veterans with opioid use disorders as well as those with chronic pain who are prescribed opioids. We've distributed more than 255,000 kits, and we have documented over 345 reversals, and that's continued to grow. This is at no cost to veterans, so please let the veterans that you know in your sphere that this is available. Next slide, please. And this illustrates a partnership with the Pharmacy Benefits Management Office and their academic detailing service together with mental health to promote naloxone education and distribution. What this slide shows is a brief description of academic detailing in which clinical pharmacy specialists provide in-person educational outreach to colleagues. They provide evidence-based information and tools, and they use basically motivational interviewing techniques to help coach providers into adopting evidence-based practices. The graph on the right shows that at a time that we were launching many different educational initiatives to promote naloxone, those providers that actually received academic detailing visits were much more likely than those who did not to prescribe naloxone. So that's been a big part of our initiative, both for naloxone distribution, for improving pain management, as well as opioid use disorder treatment. Next slide. This slide just shows some of the educational offerings that academic detailing has created. I hope you can appreciate from the thumbnails that these are colorful, easy to read educational materials both for patients and providers. There's information about marijuana, there's information about opioids and opioid use disorder. And these are available at the URL at the bottom of the slide. Next slide. We have a couple of informatics tools which really leverage the information from our electronic healthcare record to guide better patient management. The first one is the Opioid Therapy Risk Report, which was developed by clinicians for clinicians and really optimized for our primary care teams. What this screenshot shows is an individual patient report that can be used as a patient education tool. But there's also panel management tools as well. What you see from the graphs that are hard to see, the one on the left with the blue line is showing the average monthly opioid dose as well as the pain complaints, and there's really very little correlation. And that can be very helpful in helping, as you explain what the risks are, showing that there really hasn't been much benefit, can help motivate a patient to make a change in their pain management strategies. Next slide. The Stratification tool for opioid risk mitigation, or STORM, similarly leverages our VA data, but this dashboard gives a little bit more information. So this is showing a patient detail report. The first column shows the patient information and then their risk for suicide or overdose in the next 1 year and 3 years, based on our own VA historic data. And then the next little group of columns shows what are the contributing risk factors. And this particular patient, it's hard to read, but they have multiple substance use disorders, multiple mental health conditions, as well as medical conditions like congestive heart failure and hypertension that increase the risk of opioid-related adverse events. And then what are the opioids that they're being prescribed specifically and any co-occurring sedatives, hypnotics. The next little group of columns shows risk mitigation strategies that are recommended by our guidelines. It's easy to see in one place which of these have been employed. So for this particular patient, their morphine equivalent daily dose is in the recommended range, but they haven't yet been given a naloxone kit. So this makes it very easy for the provider to see which risk mitigation strategies still need to be employed. And then what are the upcoming appointments with various members of the care team? Next slide. And what we've seen as a result of these many converging strategies is a decrease in prescribing opioids for long-term use. We've had an 83% decline in opioid scripts due to long-term opioid therapy, and 90% of that reduction was from fewer new starts. Less than 10% was from increases in cessation of long-term opioid therapy users. Next slide. So now let's talk a little bit more about pain management beyond opioids. We've been talking about the risks associated with opioids, our efforts to decrease opioid use. What are we offering instead? Next slide. We have a lot of education for providers as well as patients, and this little Brain Man video is available for anyone. It's very cute and makes the points really well about why opioids aren't the best choice for chronic pain. But we have other training modules as well as patient education videos. Next slide. We have non-pharmacologic pain treatments. Again, a systematic review of the literature resulted in recommendations for what we call manual therapies like massage and acupuncture, exercise and movement strategies like aerobic exercise, resistance exercise, Tai Chi, yoga, and then behavioral strategies like cognitive behavioral therapy for pain and mindfulness-based stress reduction. And we have a directive that's requiring access to these treatments. Next slide, please. And we've stood up 18 complementary and integrative flagship sites across the country in order to increase access to these treatments. Next slide. We've also implemented a stepped care model for pain, where most pain will be treated in primary care, but more complex cases can be stepped up to an integrated pain management team, and we are in the process of implementing this across the system. Next slide, please. These interdisciplinary pain care teams must have a medical provider with pain expertise, as well as an addiction medicine expert, a behavioral medicine expert, and a rehabilitation medicine expert. These can also be supplemented with others like clinical pharmacy, nursing, and interventionalists. Next slide, please. And finally, my area is opioid use disorder treatment. And there's the headline from Time magazine about how we've gotten hooked on opioid pain medicines. Next slide. I'd just like to highlight, if you want to know the details about how to do good opioid use disorder treatment, SAMHSA's Tip 63 is excellent. It notes that opioid use disorder is a chronic and treatable illness. It emphasizes patient care being informed, based on informed, shared decision-making about treatment options, that veterans should be offered all of the evidence-based treatment options, unless there's a contraindication to one or more, and that treatment should be tailored to fit each individual's needs and preferences, and that treatment should include medication for opioid use disorder. Next slide, please. The National Academies of Science, Engineering, and Medicine went even farther, and they basically put their #1 recommendation in the title of their report: Medications for Opioid Use Disorder Save Lives. And so a key emphasis is on increasing access to this life-saving medication. Next slide, please. So back to my nurse. As you'll recall, she had developed an opioid use disorder to opioid pain medicine. I explained to her the risks and benefits of buprenorphine, injectable naltrexone, or opioid treatment program administered methadone. And she was, as I said, in the intensive outpatient program, and she selected buprenorphine. So next slide, please. Let's just talk a little bit about how these three medications work. So morphine or even street heroin is pretty short acting, and so you can see by the blue line that you get a quick, if the red-orange line, straight line, horizontal line is baseline, then when someone takes morphine, they get quick relief, but they may also experience euphoria. And then after a short period of time, that pain relief and euphoria wears off, and what we usually don't realize is that the pain actually gets worse than baseline. And that prompts the person to seek more opioids, which then they get some relief, but not as high as the first time because of tolerance, and so on, so that once someone develops an opioid use disorder, they're largely just trying not to feel sick. The way the three treatments, methadone, buprenorphine, and naltrexone, work is slightly differently. Let's start with methadone, because that's the first one that was FDA approved. Methadone is a very potent opioid. It's very long-acting. Once you start it and get up to a high blood level, folks build up a tolerance and they're able to function as if they don't have any methadone on board. It takes a while to get up to that dose, but also once they have a very high tolerance, any use of morphine or illicit heroin really has very little effect because they have such a high, they have become used to such a high dose of methadone. So it's not that they're going to get sick if they use morphine or heroin, but they just won't feel the effect. They're wasting their money. For buprenorphine, the same thing is true, that at low doses, it relieves craving, it relieves withdrawal, but it's a partial agonist at the opioid receptor, so any further use of buprenorphine has no effect. It has such a high affinity for the opioid receptor, however, and so any use of other opioids really doesn't have an effect. It's not that the tolerance is higher than for morphine generally, but it's also the partial agonist effect that prevents any other opioid use from having an effect. And again, anyone who buys illicit opioids then is just wasting their money, because if they're taking their buprenorphine as prescribed, they won't feel anything. Naltrexone is a pure mu-opioid blocker. It has no effects at the receptor, but a very high affinity and blocks the effects of any illicit opioids. Next slide, please. So back to my nurse. I think if you advance, we'll see. There we go. So she started on the buprenorphine and had a pretty amazing initial response. She had been detoxed while she was in the hospital, so she wasn't physiologically tolerant, but we started a very slow dose and brought her up to the recommended dose range. I don't recall exactly, but about 12 milligrams daily. She was able to concentrate. She wasn't plagued by craving. She was able to pay attention in classes and successfully completed the intensive outpatient program. But she really became an evangelist for spreading the good word about how effective this treatment was. And she would stop by my office and say, "Hey, doc, I got another one for you," and encourage her friends to come seek treatment. She began exercise therapy for her pain, and also was very active in 12-step recovery groups, not so much talking about the medicine there, but getting the support for recovery. And she remained in recovery on the medication for many years. Next slide. So in VA, we've been putting a lot of effort towards increasing access to these life-saving medications. And as you can see, we started out with really less than 10% of patients with opioid use disorder back in 2004 receiving these life-saving medications till at the end of fiscal year 18, 36% of veterans clinically diagnosed with opioid use disorder in the VHA were receiving the indicated medication. So we've come a long way, but we still have a ways to go. And we realized that only about half of patients with a clinical diagnosis of opioid use disorder are seen in our substance use disorder specialty care clinics. So our next step, next slide, is to try to bring the treatment to the veterans where they're at. And this is just showing the effectiveness of brief counseling together with medication for many patients with opioid use disorder. This is from David Feline and his colleagues at Yale, and his physician management or medical management model, which is essentially 15 minutes of structured counseling that includes recommendations to go to Alcoholics Anonymous and other mutual health groups, but recommendations to avoid risky people, places, and things, and do other activities that promote recovery. And what the graphs show are on the left, the average weeks of consecutive abstinence from opioids after the first 12 weeks, an average of 4.5 weeks of consecutive abstinence, and after 12 weeks, an average of 3.5. Some patients received the brief counseling plus an additional hour of CBT, and some just received the brief counseling. The additional hour of cognitive behavioral therapy for substance use disorders really didn't make a difference in this trial. Next slide. So based on that and other clinical trials, we have been promoting what we call addiction-focused medical management that can be delivered by a medical professional, either a physician, nurse, physician assistant, or clinical pharmacist in the primary care setting. And this just summarizes the characteristics of that brief counseling and close monitoring. Next slide. And we're calling this Stepped Care for Opioid Use Disorder. And we have started an initiative, trained 18 pilot teams, one from each VISN or Veterans Integrated Service Network region around the country, to implement this in either primary care, pain management, or mental health, and then also trained the SUD specialty care team to be able to support that level 1 clinic with consultation and warm handoffs and being able to provide stabilization when needed. Next slide, please. I'd just like to say a few words now about opioids and suicide risk. And that gives the numbers for the Veterans Crisis Line and also hashtag Be There for more information. Next slide, please. So there's been a lot of headlines about tapering opioids or discontinuing them abruptly, leading to suicidal thoughts and suicide. So this relationship has been highlighted in the popular press. Next slide, we'll talk a little bit more about the evidence. So co-occurring mental illness is associated with an increased risk of suicidal thoughts and behaviors in opioid-dependent individuals. And our own internal VHA data shows that veterans are at increased risk for unintentional overdose or suicide within the first 6 months of starting or stopping prescription opioid pain medicine. And that's also been shown to be true in other clinical trials of medication for opioid use disorder, particularly methadone. Next slide, please. Patients with chronic pain are twice as likely as those without chronic pain to die of suicide, and the risk increases with the intensity of pain and the opioid analgesic dose, but patients with opioid use disorder are 13 times more likely to die of suicide than the general population. And veterans within VHA are 7 times more likely to be diagnosed with opioid use disorder than the commercially insured population. So we have a high-risk population. Next slide. I just wanted to highlight this recent review by Amy Bonnard and Mark Ilgen, who are 2 VA investigators, who basically did a review and talked about that complex relationship and postulated a demand-side hypothesis that there are deaths of despair, and folks who have lost their jobs, who have lost hope, sometimes turn to opioids as a way of coping with stress. But there's also the supply-side hypothesis that because opioids have been so widely available, more people have started taking them, and opioid use disorder is associated with misery and despair. Both pathways are relevant and must be addressed. Next slide. So they, in their paper, suggested a strategy for prioritizing which risk mitigation strategies for which type of patient. As you can see, those who are on a low-risk opioid regimen for pain, basically determining their risk score, treating any co-occurring mental health conditions. But those who are on a high-risk opioid regimen need those same assessments plus cognitive behavioral therapy for suicide risk and patient-centered opioid taper and overdose education and naloxone distribution. And those who have an opioid use disorder also should be offered medication treatment for opioid use disorder. Next slide. So ways that you could help. Assess for suicide risk among all veterans with opioid use, and assess for opioid use among all veterans at risk for suicide. Use the Opioid Safety Initiative Toolkit, which is available at the hyperlink on the slide, and direct veterans to our online opioid safety information. Provide additional support, treatment, and wraparound services during transitions, both onto and off of opioid therapy for pain. And again, the risk period is about 6 months on either side of that. Next slide, please. You can also ensure that veterans who are considered for or receiving opioid pain medicine are screened for illicit substances and other prescriptions per the treatment guidelines, and address any co-occurring mental health conditions. Encourage medication treatment for opioid use disorder. That is probably the most effective suicide prevention strategy that we have. And of course, providing overdose education and Naloxone. Next slide, please. I'd like to thank my many VA colleagues who have contributed both to the many efforts that we have to address the opioid crisis, as well as to this slide set. I'd like to give a shout out to Dr. Friedhelm Sandbrink and Ms. Jenny Perry, especially for developing many of the slides in this slide deck. And thank you.
Thank you so much, Dr. Drexler. That was a wealth of information and really drives home the importance of understanding the roles that folks can play in helping to address the opioid use that's plaguing so many of our veterans and their families, and also kind of understanding the roles and the hope that's there from the various treatments as well as the innovations that VA has been taking to really kind of take a look at how we shift from dependency on such a risky, treatment method that really may not be the most effective for folks as they're learning, in great droves now. I really appreciate that so much, and I think your last few slides that talked about the roles that folks can play will be continued as we turn things over now to Dr. Flaherty to talk really about the role that individuals can play and just why it's so important for us to understand the cultural competency that comes into helping to support our ailing warriors. So, Michael Flaherty, please take it away.
Thank you, Cicely. Next slide, please. Following Dr. Drexler is often a challenge. It is such a comprehensive and thorough review of really how to treat opiate use disorder today and the model programs that are available to our soldiers and sailors and veterans and families in the VA. Before I begin, I'd like to stop for just 1 second and remember those upon whose shoulders we stand. This past Monday, we all marked Memorial Day, and so many of our veterans are there upon whose shoulders we stand, and we thank them for their service. I will be taking a little bit of a different point of view than Dr. Drexler. I'll be going more systemic. Next slide, please. My goal today is to ask you to think about what you can do to create prevention, treatment, and recovery-based opiate use disorder services for the service member veteran family population in your community. Know that there is no exercise better for the heart than reaching down and lifting people up. And we all know that there's nothing higher we can do than to serve those in their hour of need than our veterans and their families, the true 1% of the American population. Next slide, please. Today's SITREP, we are in an epidemic of opiate use and overdose, as Dr. Drexler so well pointed out. We are not alone. It's across America. It's now growing in the west of the United States, but also surging in Canada, Sweden, Norway, and Ireland as we speak. It is now being inundated further with amphetamines, methamphetamines, as cycles of distribution and addiction and interference and enforcement occur. We can talk about that if there's interest and questions. Veterans, as was pointed out, are almost twice as likely as non-veterans to have an opiate use disorder and an overdose. Particularly vulnerable are Army and combat vets, women, older men, rural vets, vets with secondary battle wounds, and I could really add homeless vets particularly African American homeless vets are the high numbers for overdose. Its causes are not just overprescribing, although we certainly have had a lot to do with that in our prescribing methods, or illicit use, but it also has psychological, social factors, and we'll talk more about that. The solutions, while they seem complex, are there, and there are many. Next slide. First, we must know our enemy. And when I was a student at the Naval War College, we studied a gentleman named Sun Tzu, a Chinese a philosopher and expert in the art of war. And he taught us, or at the War College they taught us, if you know your enemy and you know yourself, you can fight 1,000 battles without destruction. So knowing our enemy and knowing ourselves is the method of my presentation at a more systemic level. First, we have to know that the person in front of us is not an addict per se, but an alien warrior, someone who has gone to battle, most likely had incurred some sort of physical injury, perhaps psychological, and as a result of being a warrior or the family of a warrior, is now come before us for medical care. And we must address our own conscious or even unconscious stigma. This is not an addict, this is a person, an ailing warrior. In also meeting the enemy, we must provide, as Dr. Drexler said, hope and relief consistently by engaging and retaining the person and the family in care. Improve access and retention in treatment that offers best science practice and an opportunity for recovery in each episode of care. That's important. Not that we just topically treat, but that we offer the opportunity for recovery in each episode of care, thinking through what recovery could mean for that individual or their family, and do only best science and practice. Let's next understand and respect the military ethos and the culture of the warrior, working with the person in the family-centered care to help them through some of the learning and the ways that life is amongst the military, whether they be on active duty, transferred into our reserves, or into the veteran community, or even into civilian community life. Keep the center on person and family consistently as one unit. So our enemy there is to address stigma, to be sure we use only best science and practice, and to remember our ally of the person and the family, and we will not have to face destruction. Next slide, please. The military culture, something that soldiers, sailors, reservists, guardsmen, all are taught and live, is both a risk and a protective factor. And we have to realize that teaching someone to be unit-focused, sacrifice self and, over the unit, to not hold yourself separate of the group and readiness. These protective factors that help a person in combat are also risk factors when they come home to the community, because they have to be addressed, and the person has to feel comfortable to take down those risk factors or those defense systems. 65% of those seeking help will see it as a weakness. 63% of those from the military will fear that leadership might treat them differently, and that it will affect their career. 59% will fear that the peer will have less confidence in them, even their own colleagues, so they will try to hide it or keep it hidden from others, and it will be hard to accept treatment. Their lives are built around discipline, a defined professional hierarchy, and a commitment to sustaining the team and unit readiness. Readiness is the mantra of the military, and unit and readiness is at the top. Just the individual readiness is below that. The core values upon which the individual will thrive will be loyalty, duty, respect, selflessness, honor, integrity, and personal sacrifice or courage. Next slide, please. Other risk factors, and Dr. Drexler covered many of them in specific, the stresses of deployment in wartime or peace, multiple deployments. Most of the Iraqi, Afghanistan veterans have had 4 or 5 deployments now, and a cumulative effect of that is hard for a person's psychological state to just let the defense systems down. zero tolerance policies. The military has high standards on the use or illicit use of any drugs. Zero tolerance is still in effect. Stigma, as we mentioned earlier, addressing the stigma of use, but also the stigma in the medical systems when they would reach out in those populations where they are not in the VA and trying to get help. There's often what I call a medical stigma to turn people away who are users. We have to understand the power of stigma in this illness. Of course, confidentiality, service records, and readiness evaluations. So we have to always keep in mind that the person has all of these things behind them that they have to have in the forefront so that they can understand how it will be affecting them. Are they on medical leave? Are they outside of active units so that they can be protected? These things have to be considered in the treatment of opiate use disorders. Next slide, please. Some other pre-existing conditions, again, as Dr. Drexler pointed, chronic pain. I'll talk more about that. Opiate use itself. In combat, oftentimes, I had a soldier who told me he called it his go pill. He had it and he had some pain in his knees, but he took the pill and went into combat. I also had soldiers who regularly changed their helmets so that the monitor for the TBI event would not be directly associated to that individual soldier. Suicidal thoughts, easy to do when you're in a foxhole. Post-traumatic stress, high states of mental alertness. Drug and alcohol or medication misuse, depression, anxiety, and other psychological or physical wounds, all are pre-existing conditions that should be explored, are opiates in the picture. Family and financial difficulties are high. Many of our service families are struggling with financial difficulties, and they need to be understood and brought into the picture. Treating the individual as a family unit is the way to go. Sleep disturbance, again, a high indicator. Despair, loneliness, suicidal thought, and plan, as was discussed. Next slide, please. The VA itself has a document that it published in 2017 called Radical Redesign for Healthcare. And this document seeks to have patient-centered care be the heart of treatment in the VA system, and it has many guidelines. Next slide. On this particular slide, I tried to summarize some of the guidelines of the patient-centered care the VA is seeking. And of course, it has elements, as discussed, that all care be personalized, be proactive, and patient-driven. So as you're looking at the veteran, wherever he or she may be, or the active duty member, wherever he or she may be, you have to think what systems are best for that individual. How can we be proactive to address them? And how can they and their needs drive the treatment as much as we as the professionals provide the treatment? And that is in the informed consents that were discussed earlier. In the middle, the me is the person, the soldier, and their real-world experience with the practice that we offer. And in developing these healing environments, healing relationships to make this person-centered care really work. We build a support structure. Many of these, as Dr. Drexler pointed out, are in the VA system of the individuals, but about an equal number, if not more, are outside of the VA system. And how can we reach them? And that's what the next slide will discuss. Many states and counties and communities are now transforming their healthcare systems into a person-centered, similar to the VA, population-based model where building health, wellness, and resilience are part of addressing the pathology, the illness, the addiction, and the disease, and improving population health at the same time. Next slide. One such model used in many states today is called a recovery-oriented system of care, where the services within the community form a network that is person-centered and builds on the strengths of individuals, families, and the community itself to achieve measurable improved health, wellness, and quality of life for those at risk and the general population. In our case study, we would have an individual who may be going in and out of VA services or into community services in the community that are not VA, but may in fact be paid for by some of the government insurance plans, and we'll talk more about that. But building the network of services, using both VA and non-VA services to reach all veterans is the model of a network that we're talking as a recovery-oriented system of care. Next slide, please. A ROSC is a coordinated network of community-based services and supports that is person-centered and builds on the strengths and resiliences of each individual, the families, and the community itself to achieve improved health, wellness, and quality of life. These documents you see behind are SAMHSA prepared or supported documents, and there's a whole library, hundreds of articles on how to build a ROSC in your community. Essentially, we'll talk about it briefly, but remember, it's a network so that you can reach all individuals and families through multiple systems, both VA and non-VA, through the focus of the individual driving the care for the personal recovery that they can find. Next slide, please. How to begin to design your ROSC for service members, veterans, and families. First, think of what you're doing now and the care that you're doing specifically to the agencies that you work in. But back up and gather all the providers in a geographic area to ensure that they have, one, are military culture informed so as to complete a continuum of care for this service member and veteran and family. So you have to think of the continuum of care of what would be needed, and we'll talk more about continuums in just a moment. But that's every level of care that would be needed for an individual or family so that you have a network then pulled together in a geographic region built around your VA centers, but also what might be available to you in the civilian community to complete your network. Define goals and recovery amongst this group so that you have a vision, a common vision, objectives and elements of care. SAMHSA itself has suggested in the documents I showed and others, and there's, as I said, there's over 300 now, to attain and sustain recovery. Recovery is not commonly defined in communities, so you want to do that. You want to have meetings where you can have common discussions and define recovery. And after you pull your network together, establish 24/7 access for care to individuals and families and match each person to the most appropriate level of care. Next slide, please. Offer each person a peer support or battle buddy. When they enter the system at whatever point, the first person they should see is somebody that will help them through the system. And offer the battle buddy to the family also. Seek technical assistance for ongoing ROSC development in the community where you design. SAMHSA supports both the Great Lakes ATTC and the National ATTC that have trainers and literature that can help you with this. And if not, send me an email. I'll be glad to direct you to sources that can help. Next slide, please. Elements of a service member and veteran family recovery model would include first prevention education. You want to have people understand about the power of opiates and about pain management and suicide, as Dr. Drexler is so adequately laid out, and also about access to Narcan, so that anybody on a prescription or on illicit opiates has access to Narcan. It's just a good precaution. Early intervention, how to do brief screens, SBIRT, others that you can understand if the person's appropriate for treatment and for what kind of treatment. Is indicated that 36% of VA people are getting medicated-assisted treatment, but we still need more. Most of the nation is around 20%. Experts believe we should have, with the opiate strength in the individuals, about 60% total on MAT. Decrease access to opiates, which is, as you've heard, develop your prescription drug monitoring programs, work with them, and your medical education and management, so we have more physicians who are wanting and capable of practicing and get with this particular population. And build community supports for vulnerable populations with the use of peers. A recovery-oriented system of care is built around peers, those in recovery who have had the experience, whether they be a parent or the person themselves in recovery, and that can help others in the situation. Building up your peer support for your regular treatment programs. Next slide, please. Treatment itself, as we said, increased access to medicated-assisted treatment with close medical monitoring, which is the key to best MAT treatment. Increased access to behavioral treatment, peer support, community support, military career benefits. Understand their benefits and help them through it. Many of them do not understand all of the benefits that are available to them, whether they're in the VA system or on their own, or even outside of that with housing and more initiatives that are coming along the way now. Next slide. Secondary prevention consequences in your SMF ROSC. Integrate medical care with benefits in the network, as you saw with the VA model and infectious disease. Look at these things. Talk to your physicians and your hospitals about infectious disease presentations, about pain, depression, suicide, surveillance, and sustained wellness and recovery, keeping in mind that you want to treat always the pathology and build wellness and recovery, not just treat the pathology. Next slide, please. Steps in treatment. My presentation on steps is a little bit different because I'm speaking more systemically, but the people at the decreased risk coming down, the woman and the man that you see, they're probably the people who come voluntarily into treatment and can access the treatment, whether it be at the VA or in the community. Those on the horizontal platform are those who come into the population almost inadvertently. They are an overdose survivor, they are arrested, they come to an emergency room, and that kind of intervention treatment is different than those on the first steps coming down, where it's open and voluntary. We need to recognize more openings for those coming to the emergency rooms and to the overdose situations so that we can hold them into treatment. 63% of those who have overdosed had been prior in treatment or in the criminal justice systems. So we needed to get more stickiness to our outreach to hold them. The individual on the top step is perhaps the hardest one, and right now in America the largest number of overdose deaths are in that level, those who just simply do not want help at all. They just want to stay in the world as they can on their drugs. Here you get into this thinking such as harm reduction and outreach, medicated assisted treatment, certainly to get that individual down from the third floor onto the second and into the first as they go along. But it's a much difficult population, and we have to define and work with each of the members on each level with different kinds of interventions, stronger than others. Next slide, please. The treatment of our individuals will come across the military system, either from military hospitals, to us, or from the VA treatment centers. Vet centers will bring us community. The insurance that they have can often be a barrier. We need to understand TRICARE, private insurance, Medicaid, Medicare, public funding, and unite these models so that they can support the individual. In many cases, if TRICARE does not cover a community program, there will be other means from block grants and from county support to cover the services so we can be sure we have a solid continuum of care. And many agencies can now, and physicians, apply and become accessed into TRICARE. It's much easier than it was just 5 years ago. And of course, there's the Mission Act of 2018, which is about to be expanded in June 6, which opens up even greater opportunities for individual practitioners, small agencies, and physicians to access the financial supports they might need to treat the veteran population. I also put down the Find Treatment SAMHSA site here, which if you are in a rural area looking for how to find the closest program for your veteran, just link onto that and you will find the closest programs. Next slide, please. Understand the military culture, a critical first step to both risk and protective factors. We've talked about the warrior ethos and structure in the military. Has to be considered as embedded in the individual. Build a local vision in your network. Come together around it, put your continuum together so all levels of your continuum are in place, and improve access to achieve health, wellness, and recovery over time through person-centered care. First steps of building your ROS. Next slide, please. address four critical elements in the person-centered care. First, I mentioned repeatedly today, coordinate care across all systems for the person and the family. Offer a continuum of care that builds measurable resilience, health, and recovery. Address workforce development, which is critical in our country today. We are at a shortage of competent workers in the behavioral health field. Psychiatry, psychologists, social workers, counselors, nurse practitioners are all needed. Establish and monitor SMF outcomes with the added community services over your continuum and your continuity of care with the peers and families being added as support to the outcomes and those clinical outcomes. Next slide, please. This is a page from the ASAM criteria. Each of these levels is a level of care that you would want to have accessed in your network. So you'd want to have something that can do early intervention or have those skill sets involved in your providers, your outpatient programs, including MAT at larger percentages, intensive outpatient, residential. And once you put your continuum together, you have the safety net that is needed for our veterans. And ASAM gives us the guidance on this, and it really is excellent. Staffing patterns, et cetera, for all of the levels of care that are found to be appropriate to address an opiate use disorder. It's a great guidance. Next slide, please. Again, involving the family, the person as a unit, peer support, Narcan, 24-hour access, looking for earlier intercept points. The key on this slide there is that in reviewing overdose deaths and overdoses themselves, in addition to finding the 63% had prior contact with the system, we also found out that we could change the systems to adjust to those weaknesses in the system. So every single overdose is recommended to be reviewed so that you can strengthen your systems, not find fault, but strengthen your system so that you can hold the veteran, hold the family member, meet their needs even better. Next slide, please. As, again, Dr. Drexler pointed out, post-Iraq, Afghanistan veterans, 31% will be coming home with post-traumatic stress, 19.5 TBI, et cetera, et cetera. And these, on both sides of the slide, the physical pain symptoms and their percentages and the psychological symptoms that you find on the left-hand side are all triggers for where you may find opiate use, or certainly even sedative use. About a third of those on opiates are also using sedative, which is a bad mix, very dangerous mix, and you want to get to those as quickly as we can and get people into treatment. But those are the numbers that we have to look at to see if we can find opiates or even sedative use. Next slide, please. System measures, what I like to say in the Navy is we set the course for all ships and they go to it. And setting the course for all systems, you want to have a unified vision at your system as you pull it together. You want to be culturally appropriate. These are measures. Have you done training in a culturally sustainable via systems linkages to build on person-improved institutional relationships? Augment of workforce measures that you have to show that your system is addressing and capable of addressing the needs of this SMVF population for the opiate use disorder and, in fact, for mental health and substance use in general. Service providers, if you're part of a provider agency, are you doing integrated care? Can you change your military awareness so you understand the culture that we're talking about? Earlier outreach to the population, linking with your VA centers. Many communities have VA centers that don't, in that community, have health services, but they do have VA centers that can help and work with you and get people to come into treatment and keep them into treatment through the use of peers. Individual and family reductions, and your measures there are, of course, the ones that we all would talk about: reductions in alcohol and drug use, depression at job, improved family, improved service to, giving back to the community. And there's a citation there that, there are 14 measures of individual and family recovery that in this new emerging science of recovery we can use in this population and you can use in your work through your system. Next slide, please. We can do this. We're all together. This is not something that cannot be done. In fact, it is being done. Next slide, please. The military mottos, when each member comes into the service, they are taught and live their particular motto as they go through every day and actually sometimes for the rest of their life. We learn simple things, for example, make your bed. But each of us have a motto. Next slide, please. I'm suggesting today in the presentation a new motto, Semper Cavallucit, always recovery. Think of your services to the individual and the family as not just individual care for that particular time and place and treatment. Think of it as overall attaining recovery and anticipating what the person will need in the military life and with their service and with their health so that they can always attain recovery. We all know members of the SMVF population suffering with PTSD, chronic pain, opiate use, a number of those who have contemplated and followed through with suicide. Our OP plan must be fully aware of the precursors our military and their families bring to any care they seek from us, particularly for those who have served in combat. As well, our health systems must offer care that is culturally competent, best science and practice, offering in each episode the opportunity for health and wellness and recovery to each member and family. It's the least we can do. Next slide. We all know what to do. Can you imagine what we could do if we do all we can? Next slide, please. Thank you very much. Next slide.
Thank you so much, Dr. Thank you so much, Dr. Flaherty. I think we definitely have kind of our marching orders, so to speak. I think our message is clear that the work that's going on both within the VA, within communities, identifying recovery supports is just, it's come quite a far way. And while we don't always hear these stories of hope in the media today, we want folks to know that they have a great role to play. So we'll transition back to Sam for questions. I just wanted to say again on behalf of SAMHSA and the SMVF TA Center, thanks for both of your presentations. Quite informative, and I think we'll have a great last few minutes together answering the questions from the audience today. Thanks, Sam.
Thank you. So I encourage everyone to send in their questions. Although I know we have some limited time, we'll do our best to get to most of them. I wanted to kick it off with kind of a merger of a few questions and open it up to both of our presenters. We have several questions that are really tied to what are the approaches or best practices in determining when or if to use medication-assisted treatment and which treatment option to use. And there's also a secondary question about strategies for managing resistance to medication-assisted treatment in the traditional recovery community. So wanted to open that up to both of you to get your feedback and perceptions.
Well, this is Dr. Go ahead, Karen.
Go ahead, Flaherty. Go ahead.
Okay. Well, I was going to just say that there is a divergence of view on the acceptance of people being on MAT in the recovering community. However, there are books, and many of those in recovery will advocate for a person being on MAT as being capable of saying, I am in recovery. And there are many books written on that, too, research, others, William White, others who have written them, and I can direct some people to those if they would want to read them. Essentially, it comes down to this. If a person is medically stabilized on a medication prescribed by a physician and taken as prescribed, that person has that one aspect of the 14 under control, much like glucophage and insulin for diabetes. So that one aspect is stabilized, and they can go on to the other 12 or 13 measures of recovery where they can excel, and therefore they can go to meetings and say, I am on recovery, even though I am on MAT, it's stabilized. However, that does not allow them then to go back into active duty or into military service. That's a different matter altogether. Dr. Drexel?
Thank you. I give a little bit different perspective. I'm going to speak to the evidence from randomized controlled clinical trials. So those are the gold standard of determining whether treatment is effective, because we all have our own sort of screens and filters by which we see things, and so we may introduce some bias. But there's a really landmark randomized controlled clinical trial by Kako and colleagues from 2003. We spell that KAKKO, published in The Lancet. And this was a placebo-controlled trial. It may be the last that's been done, though, because the results were so dramatic. So 40 patients were randomized to receive either buprenorphine or placebo. 20 received buprenorphine, 20 received placebo. Those who received buprenorphine, 75% of them were retained in treatment for a year, and 75% of their urine drug tests, which were done frequently, were negative for opioids. Of the controls who received placebo, all of them had dropped out of treatment by the second month. And of those who were randomized to placebo at the end of a year, 4 of them had died, none in the buprenorphine treatment group. So those results are so striking and so dramatic, and the importance of the life-saving properties of buprenorphine can't be overemphasized. But I do think the treatment should be patient-centered, and if a veteran comes to me, I talk with them about all 3 options. I think injectable naltrexone, which is recommended by our guidelines, is an important option for patients who are reluctant to take a medicine that activates opioid receptors. And people have a variety of reasons for that. But if they are reluctant to take a medicine and they come to me saying, I don't want a medicine, doc, I say, let me talk to you about this medicine, because in other randomized controlled clinical trials, comparing injectable naltrexone to buprenorphine, injectable naltrexone is just as effective at reducing craving, reducing relapse as buprenorphine for patients who are able to start the medicine. And the challenge is the hurdle. You have to be opioid-free for 7 to 10 days, and that's very hard for someone who's caught up in an active addiction to achieve. But if they've been detoxed, either because they're in a controlled environment with the criminal justice system or in a hospital for treatment of a medical complication, starting that injectable naltrexone could be life-saving and can help them on the road to recovery.
Thank you so much. Hopefully that answers everyone's question. One more quick question, and then I think we're coming up on time. And Dr. Drexler, this is for you. The question is, how does a veteran access the overdose education and naloxone distribution program? Would it be just presenting at a local VA and those services are provided there?
Yes. So anyone in our system who can prescribe a medication can prescribe the naloxone. And thank you to Congress for passing a law so that that naloxone prescription is exempt from any copays. So any eligible veteran in our system can talk to their primary care provider or mental health provider and ask for naloxone, and they can receive it.
Great, thank you. Okay, so I think we're coming up on time. So Cicely, unless you have anything to add, I'm just going to do a quick wrap-up.
Nothing at all. Thanks so much.
Great. Okay, great. I want to thank you everyone for attending today's webinar, as well as our fabulous presenters. I want to reiterate that the slides and a recording of this webinar will be available both on our website and distributed to participants within 48 hours. And thank you for attending. SAMHSA service members, veterans, and their families' Technical Assistance Center presents Opioid Addiction, Increasing Access to Prevention, Treatment, and Recovery. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. On behalf of the National Council, Policy Research Associates, and SAMHSA's SMVF TA Center, I'd like to thank you for joining us today, and please enjoy the rest of your day.